fine. So it's
There we go.
There you go.
So we're delighted to welcome Dr. Denise Tiran.
Yeah.
Tiran, sorry.
It's all right.
And she's going to talk to us.
I have to say, autocorrects to Titan every time you try and type her name on social media.
Tell me about it.
But I quite like that. It's got a good ring to it. Sorry, Grania.
No, that's fine. That's fine. And Denise, if you would just like to introduce yourself and give yourself a bit of a background. We've been chatting, and yeah, it'd just be nice for others to know a bit about yourself.
Well, that's great. Thank you very much for asking me, and it's really good to be here, even though I know that most of the potential audience is out there doing stuff, so it's great to be with you anyway. And so yes, I trained as a nurse first, just because you had to in those days, a long time ago, and went straight into midwifery. So I trained at St Bartholomew's in London as a nurse, and then went to Northwick Park in London to train as a midwife, gained a little bit of experience, and then went out on the community in Surrey, which I loved and is what I think midwifery is all about. And when I talk to student midwives these days about what it was like, they can't believe it, because the care and attention we were able to provide for expectant and birthing and postnatal parents was phenomenal compared to now. I then moved into teaching, and initially I was at a small hospital in central London, and then moved to what eventually became part of the University of Greenwich in southeast London. So that was when was that? The early 1980s, and stayed there until I left to set up my own business. And during that time, I started to look at complementary therapies. I sort of it just came along, and I got interested, and one thing led to another. And I don't know if any of you have trained in a different therapy or whatever, but you often find that the next one is added on, and then you think, oh, I'll do that one as well, and then I'll do that one. So I started by doing a massage course at the University of Surrey, actually. Went back to the student midwives and was teaching them about how to use touch and massage, particularly in birth, at a time when it was all a bit witchy, and I think they thought I was the resident witch, actually. And
That's a compliment.
I suppose it is, really. I then went to do what I thought was going to be a reflexology course. And it turned out to be reflex zone therapy, which is a German style of reflexology, but very, very much more clinical than generic reflexology. And I had my son, Adam. He was 9 months old at that point, and he'd been born at home with a forceps birth because he was 4.3 kilos. So don't go there. And I was still breastfeeding him. So, I was working. I'd feed him in the morning, feed him in the evening, and go run in the loo at lunchtime to express, like you do, and take that home. And whilst I was on this reflex zone therapy course, I started to produce more milk as if I was newly birthed, sort of third or fourth day postnatal. And I said to the teacher, what's happened? She said, well, yesterday we were working on the parts of the feet that correspond to the endocrine glands. Your partner that you were working with has just slightly overstimulated the point on the big toe for the pituitary gland, and that has caused you to produce more milk. And that was like a light bulb moment for me. So I really began to explore the potential of different therapies. And I would say reflex zone therapy is my own personal favorite. I can work with many, many people and successfully treat a lot of their different conditions. And whilst I was at the University of Greenwich, I actually did some research on using reflex points on the feet to predict stages of the menstrual cycle. So from the feet, you can work out where somebody is during their menstrual cycle, obviously on non-pregnant women. And then you can work out which ovary is active that month and predict roughly when the next period will be. So that was a very interesting piece of research that I did. And after the reflex zone therapy course, I think I went off and did an aromatherapy course, which was rubbish, actually. The teacher was rubbish. So we more or less taught ourselves. And I was very interested in the scientific side of it, the oils and the chemistry and that sort of thing. Slightly less interested in the massage, although, you know, it's got its place. But I'm not the best person to do massage, or to teach it. Actually, I have lecturers who teach that subject. And then as I sort of developed further, I looked at Chinese medicine with moxibustion, and I've done an acupuncture course. And although I don't use it in practice, but I obviously know the theory. And also herbal medicine. I'm very interested in herbal medicine and homeopathy. So it gradually developed, you know, I was still at the University of Greenwich, and I was given the opportunity to develop a degree in complementary therapies in the early 90s, which I ran until 2004. And I decided to leave the University of Greenwich and set up my own education company. The reason being that the general public was becoming much more interested in complementary therapies, but didn't really know where to find credible practitioners. Midwives are being asked by pregnant women about where they could find therapists. Therapists were wanting to specialize in working with expectant and postnatal parents, and yet there was no real education focused on pregnancy, specifically maternity. So I left the university, set up Expectancy, and I have a team of teachers who work with me. They're all freelance, and you know they work for themselves as well. And we've been going for 21 years now. So we offer a whole range of courses, primarily for midwives, but we certainly welcome doulas, and we occasionally have maternity support workers or health visitors. We've even had an obstetrician on one. Yeah.
Wow. Well done, Denise. Well done.
Yeah. They're not actually quite as skeptical as some senior midwives, believe it or not. And when it comes to moxibustion, medical staff are more in tune with it than you might expect, and certainly more in tune with it than high-level midwifery managers. Because the Royal College of Obs and Gynae Green Top guidelines on breech actually mention moxibustion. So they're not quite as skeptical as you might think, really. It was quite good. So yeah, that's what I've been doing for the last 21 years. And I do a lot of teaching for NHS trusts, mainly around setting up aromatherapy services for birth, and also much more now post-dates pregnancy clinics. So I teach them a combination of acupressure points and aromatherapy and reflexology. It's a whole package that they can implement. And some hospitals have had a lot of success with reducing induction rates simply because women are overdue. You know, it's been quite successful. I've written quite a lot of books. In fact, I say to my students, if there isn't a Turan reference in there, you might lose a mark, not because it's me, but because sadly for them, I've written many of the books on midwifery complementary therapies. And we also offer business training for midwives wanting to leave the NHS, and that at the moment is the biggest field of work. They come to train in the complementary therapies, but they also want to do the business training and mentoring scheme that we offer, because it's a scary job moving from the NHS. In fact, I think midwives often think the NHS owns them, but of course I have to set them right on that bit. So that's a bit about me. I live on the southeast London-Kent border near the Dartford Tunnel, not in the Dartford Tunnel, but fairly near it. And I've got one son, and he is in South Africa. And then my partner is still a lecturer at Greenwich. He teaches anatomy and physiology. So that's me. That's me.
Lovely. Can I ask you a question, Denise, already? Sorry.
Of course you can. Of course you can.
The complementary therapies that you do in the NHS, how long course is that with them? Is that a day or is that a few days? How long does that?
Yeah. It's usually a few days. I think one of the problems that we face is that midwives in particular, and in fairness, some doulas would love to do a really quick course and think that they can then go and practice. And of course, it is a combination of theory and practice. It isn't just about let's mix up a few oils and throw them around.
Number one, two.
Thank you. So an introduction to aromatherapy is a couple of days. If they want to do the post-dates pregnancy, that's 3 days. Reflex zone therapy is 6 days, but we don't do it as a 6-day block. We split it up. Clinical hypnosis is similar. It's about 6 days, but we also offer longer year-long academic programs where they can really study therapies and then get a license to practice in private practice. The short courses, they're only for NHS work. For them, I mean, any doulas who wanted to join them would be for information or adding to what you're already doing, really. And I'm sure many doulas are using different aspects of complementary therapies. My personal philosophy is around safe practice. And it worries me that there are a lot of midwives out there who don't particularly want to spend that time on the theory that's necessary to understand what they're doing and to do it safely. So it's quite a big problem, really, but that's because they can't afford to spend a lot of time doing long course, and then their managers will say, well, we can't afford to pay for it either. So it's a bit of a spiral, really.
Okay.
Okay, shall I make a start on moxibustion then? Have any of you used it before, or had experience of it, or had parents asking about it? Yeah. And
to turn my first baby,
right,
who's now 19.
Oh gosh, wow, that is a long time ago for that to have been available. I mean, it was, but it's unusual to hear of somebody who's had it that long ago.
Oh, is it? Oh, I don't.
Yeah.
I don't even know how I came across it. Well, I was doing everything to Turner. I was doing handstands as well. I remember my husband coming home and having a heart attack. I was doing handstands against the wall on the bed.
You're supposed to do them in the pool to help with the.
So yeah, and actually Denise, she was born at Norfolk Park. So yeah,
she?
Yeah, that's my local trust.
Yes.
But yeah, she turned. So yes, I did do it, and they sent me home. So I had some acupuncture, and they sent me home to do it at home.
Yeah, that's right. Yeah.
Yeah, and so yeah, I did do it, and yeah, she turned. So yeah,
Brilliant.
I'm a firm advocate.
I mean, it's about 68% successful, so that is better than evens probability. It's good, and it's a very simple and very inexpensive sort of technique to use. What about the rest of you? Anybody had clients asking about moxibustion? Yeah, I mean, it is very much more popular now than it was even 10 years ago, actually, and I think the NHS is having to wake up to the fact that a lot of people are asking about it, or they've used it before they have, external cephalic version for the doctor to turn the baby. So, I think we're going to see more of it because it's a simple, inexpensive, and reasonably successful technique. It's, it hardly costs anything really, apart from a bit of time. So
do you think that increases in a large part due to the term breech baby trial that's basically eradicated breech vaginal birth?
Yeah, let's not even go there, shall we? I mean, we all know it's a load of rubbish. It was a very poor study. I actually think finally obs and gynae and midwifery is getting past that particular study, although there are still people who talk about it. But I think your point is well made, that has had a negative impact on people understanding that a breech presentation is not an abnormality. You know, I mean, when I was a student, and we are talking a long time ago, the late 70s, we were expected to conduct breech births in our training under supervision. They were considered to be a normal part of, you know, the whole childbearing experience.
Yeah, so when you were back teaching and training, it wasn't an emergency, because it's considered under emergency skills now, isn't it? And I think that puts a lot more fear in people
It
to
does,
act.
yes.
Yeah.
We had midwives who were absolutely expert in helping women having a breech birth, who didn't need the doctor anywhere near them. You know, they were just so skilled at facilitating that birth without it being an intervention and an interference in the physiological process. And that's what it should be. You know, who's to say that all babies are head down, you know, if they're bottom? If they're across, oblique, or there's transverse, that's a different matter. It doesn't mean they can't have a spontaneous vaginal birth, because if it turns, it's fine. But there are more risks if it's oblique or transverse. So, but breech is, you know, straight down the middle, and it should be okay. But yeah, we've got big fights, and it always has been like that. You know, since the early 80s, when we had changing childbirth was a series of reports that the government brought out about how awful we were getting with all this intervention. And then in 1993, no, that wasn't changing childbirth, that was maternity care in action. In 1993, we had changing childbirth, which was another government thing to say that we're getting too interventionist. And then in what was it, 2016, we had better births, and so it goes on. You know, I've been a midwife nearly 50 years, and it's always been the same. It's always been this battle to keep women and birth and, you know, this life event as something that is okay, and you know, it needs to be retained as a private life event without people coming and sticking needles in, and you know, all sorts of things. So yeah, but I think your point is well made, Shelley, because attitudes towards breech are very much, even now, very much it's a problem. And let's not even go down the when does a pregnancy end argument. That's my latest bugbear. My last book, which came out in 23, was about post-dates pregnancy, and the statistics are just dire, absolutely dire. But we're not here to talk about that today. Maybe that's another time. So let me go on to the slides. And oops, oh sorry, have I got that? Can you see that?
Yeah.
Yeah, okay, that's great. Okay, so I've put some information in. Bear with me if you already know it, because obviously I thought I ought to set the scene. So, you know, let me know if you want me to whiz over anything, or if you want me to spend a little bit longer time. But it's generally felt that breech presentation will occur in between 3 and 4% of pregnancies. Then parents are given some options, depends how it's phrased, of course. The easiest medical option is we'll offer you an external cephalic version, see if we can try and turn the baby, and if not, you will have a cesarean section. Or sometimes they're not offered the ECV, and they're just, you know, told we'll book you in for a cesarean at 38 weeks or 39 weeks or whatever. Very few embrace the notion of a vaginal breech birth, but of course that's what we're talking about, and that's what we should be aiming for, unless there are other problems that mean that it's going to be less likely to be successful. I would pose the question, is there really a choice for those parents going through the NHS system? I don't think they do have a choice. If they end up with a spontaneous vaginal breech birth, they're very lucky. And it might just be because they've come in late, or maybe they're at home, or maybe those families who choose to free birth, you know, they may be happy with it. But I don't think there's a great deal of choice. They do. A lot of couples or families will ask about the alternatives. And I think it's important to say that there are other choices, other alternatives. But what is important is not to use them all together. This applies to all sorts of things, whether it's breech or post-dates pregnancy or back pain. They shouldn't all be used all together, because that might actually make them less effective and cause complications. So just on the point of complementary therapies, obviously these are a range of different strategies, different therapies, which sit largely outside mainstream healthcare. The NHS doesn't really embrace them very much, particularly because the NICE guidelines don't support them, which is a bit of a shame. But what they should be doing is enhancing existing conventional treatment or providing different options for people. And I think that's important here with the breech presentation. They're not always as well evidenced as other aspects of healthcare, although I do think it's a bit of an easy excuse to say, oh, there's not enough evidence. There is a lot of evidence if you know where to find it, but the problem is that because complementary therapies are worked on the notion of individualizing the treatment, and not everybody will get the same treatment, that doesn't fit randomized controlled trials where you have a control group and a study group. So it's very easy to say there's not enough research. There is, but you need to know where to find it. And the problem with moxibustion is that a lot of the research has been done in China and is published in Chinese language journals. So they don't always translate very readily into English, which adds to the problem. I think despite the changes and the improvements we've had in the availability of complementary therapies, there is still a lot of skepticism. But as I said, in maternity, I would say it's less so from medical staff. If someone can stand up and say, here's the evidence that it works and that it's safe, but midwifery managers can be very antagonistic towards complementary therapies because they think it's going to take up a lot of time or cost a lot of money, and that's their priorities. So it's very variable in the NHS, certainly. And I think the majority of people generally, I mean, not just pregnant people, but the general public, they will choose to go to a private therapist or clinic of practitioners because it's less available on the NHS. Obviously, many of the therapies like massage or aromatherapy or reflexology are seen as relaxation therapies, but they're also very powerful in their own right. The chemicals in the aromatherapy oils can have a medicinal effect. The techniques that are used in things like reflexology or acupressure, which is like acupuncture without needles, again, can be very effective in treating specific conditions, nausea and vomiting in pregnancy, backache and sciatica, that sort of thing. And of course, we've got moxibustion for breech presentation. So moxibustion, moxa, whatever you want to call it, is part of the traditional Chinese medicine system, which is ancient. And most people associate it with the needles, the acupuncture needles. Obviously, that is a part of traditional Chinese medicine, but an alternative would be to use thumb and finger pressure on the acupuncture points around the body. So you've got needling and then you've got just thumb and finger pressure. It's often combined with Chinese herbs, so that will be herbs that grow across the whole of Asia. Sometimes they use massage, a particular type of massage, which is called 2-in-1. And it also sometimes incorporates exercise therapies like Tai Chi and Qigong, very similar sort of things. Moxibustion and cupping are two additional techniques that are used. So moxibustion uses a heat source to warm the energy points. Cupping, like you can see in that little picture at the bottom, it's a bit extreme, that one. Cupping involves putting small perspex cuts over acupuncture points around the body to draw out excess energy. So traditional Chinese medicine is all about one's internal energies. And it's believed that we have a large number of channels, energy channels called meridians, that run around the body. They link one part to another. So the Chinese medicine practitioners would never see somebody as a load of engine parts to be taken apart and put back together, like we tend to do in conventional medicine. They're looking at the whole person, which is very fundamental to complementary medicine anyway. But in Chinese medicine, the theory is there are these energy channels. They carry our different energies or our life force around the body, and one part can impact on another. So if one part is out of kilter, it may impact on another part of the body because of the way the energy is flowing through the energy channels. The energy is called qi. It's spelled Qi, capital Q and an I. It's pronounced qi. So when we're talking about energy, we're talking about qi. And for the purposes of modern Chinese medicine, it's now been refined, and there are 12 main meridian energy channels, plus 2 single central channels. So the 12 main channels are bilateral, and then there are 2 single channels, one down the front and one down the back. And along those energy channels, there are focus points. It is thought that there's something in the region of 2,000 or more focus points around the body, but in practice, only about 200 or so are used by TCM practitioners. There is Western medical acupuncture, which is a little bit more reductionist. So rather than looking entirely at the whole person, a doctor or midwife or nurse practicing Western medical acupuncture would say, well, here's the problem. These are the points we're going to do something with, rather than a total holistic assessment of the person before starting the energy work. So traditional Chinese medicine is based on the fact that it's believed there are 8 principles that influence our body. Yin yang, which I'll come back to in a second, whether the energy channels are empty or full, and whether the pulsation from the energy points, the acupuncture points, are empty or full. Are they bounding, and do they sound or feel like a really full sort of point, or is there nothing there? Can you not feel anything in the point? That sort of thing. The principle of heat and cold is also fundamental to Chinese medicine, as is the concept of energy being excessive or deficient, or in the middle, stagnant. So your energy is generally flowing when you're in good health, optimum health. That means physical, mental, emotional, and spiritual well-being. Your energy will fly around the meridians as it is meant to do so. But if you are out of sorts, if you're unwell, then there will become either blockages of energy, too much energy, too little energy, that sort of thing. And so the treatment that a TCM practitioner or an acupuncturist would use is depending on trying to unblock the energies or slow down the excess or increase the deficient energy. So it's all about your internal life force. When we talk about yin and yang, and I'm going to go through this in a little bit of detail in a moment. Basically, yang is heat and yin is cool. But there are other features that characterize both yang and yin. So yang is considered to be the south side of the mountain, which is deemed to be favorable. It's about heat and light and activity. It's determined as a positivity, but I don't mean that the opposite is negative as a bad thing. It's just the way they describe the energy. it's also attributed to being a masculine characteristic, whereas yin is very feminine, but it's much cooler and it's darker and it's introspective. So somebody who's very quiet and self-contained is likely to have more yin energy, this cool energy, than yang, and is slightly more passive, is not a sort of person who necessarily races around like an idiot trying to do stuff, whereas a yang person tends to be somebody who's very, very dynamic and gets on with things. And neither of these are seen as negatives. They are just the way we are. So we are all a balance of our yin and yang energy. I am very much more yang than yin. And from briefly speaking with Grania and Nicola, I would say Nicola is yang and Grania is probably a little more yin. So, that's a very big generalization that I've just a few minutes of chatting to you.
And
Obviously,
a very accurate observation, I would say, in the couple of minutes that we had to just chat.
The assessment, of course, is much deeper than that. I can't just look at somebody and say you're yin or you're yang, but it does govern the way we are. So if you're more of a yang person, you've got that energy and activity. We might have even a yin person might go through periods of yang energy because they might be more alert. Yang people in the morning, yin people might be more alert in the evening. That's a generalization. We tend to say yang people largely have personality A, whereas yin people may have personality B. Testosterone versus estrogen driven, and that's not just men and women, it's the sort of way it works. Constipation versus diarrhea, that's an interesting one because constipation is a slow thing, whereas diarrhea is a fast thing. And you might think, well, surely that's a yang thing. Maybe it's the wrong way around. It isn't actually. But yang people might be more prone to constipation. A yin-yang difference as well is pre-orgasmic and post-orgasmic during intercourse. The beginning is all activity, and then what do people do after the orgasm? Go to sleep. So that's your yin. That's finished with the yang bit. We've now gone to sleep, and that's why that is a yin sort of activity or lack of activity. When it comes to pregnancy and birth, it is quite interesting because yang, remember, is energy. So when the ovum is developing, the follicular phase before ovulation is the activity, and then after ovulation, that expelled ovum will either become an embryo, or of course it will get passed out in the next period, but that is a passive activity. It's going to happen whatever you do. Menstruation is a yang activity because blood is associated with heat. But the other side of that is subfertility or impotence, or, in men is a yin thing. It's lack of energy, it's lack of wellness. In pregnancy, the developing embryo or fetus is the yang, lots of energy needed to grow all the organs. Interestingly, although pregnant women, their body temperature increases slightly throughout pregnancy because of all the extra weight and the activity that's going on, they themselves are quite yin. It's the baby that is yang. It's the baby that's growing. And in some respects, the woman's body is just holding the baby and allowing it to grow within her. So that's an interesting perspective, because you might think pregnancy would be a yang activity. Oxytocin versus progesterone. As you know, oxytocin stimulates the uterus to work. Progesterone maintains the relaxation. So that is a passive activity. Now, in labour, it's interesting because the first stage and the second stage of labour are definitely yang activities. There's a lot going on. The baby is getting ready to be born, and the woman's body is doing a lot of work to achieve that. The third stage of labour, the placenta, is actually a yin activity. It's going to happen whatever you do. So it doesn't need a whole load of extra yang activity. And for the woman, the postnatal period is also a yin activity, cool. And I don't know if you've ever looked after Chinese women. They often sit with scarves around their necks in the postnatal period. They're encouraged to stay in bed to keep warm, and they're given warming suits. And that's because in order to return to their non-pregnant state, they need to keep warm and allow the yin energy to be dispelled and replaced with some yang energy. Now, you probably think I'm talking a load of rubbish because it's quite difficult to grasp this concept. But does anybody want to ask me anything before we move on a bit?
I was just going to say that it's quite a common concept in lots of different cultures around the world, because in Mexican midwifery, it's all about getting the heat back in the body after the baby's born as well. I've supported quite a few Chinese mothers, and they would only drink hot water during the birth. So like trying to source that in an NHS hospital, they're like, well, she's got a tub of water. I'm like, no, it needs to be warm, it needs to be really hot water, because the cold is not good for her energy. So
yeah, absolutely. And you know, one of the difficulties I think that we experience in the UK now is that because we have such a multicultural society, we don't know necessarily about that particular culture's you know, habits and beliefs around pregnancy and birth, but also they may be bringing in herbs. They may have got them from the internet, or they may have been sent them from their home countries, and that can lead to other problems, because midwives and doctors, and probably some doulas, would not necessarily know whether those herbs were appropriate, whether they would interact with medications, you know. So it does bring us some new issues, but I don't think we make any attempt to try and help people who are from a culture where all these indigenous herbs and different practices are used. I know midwives who've been to Mexico and places and had and learned so much about birth, as Shelley was saying. You know, it's very much something that we ought to be knowing about when we're looking after people from other cultures and other countries. So that bit was about our normal yin yang balance. But if things start going out of kilter, it doesn't necessarily mean you're ill, but if you become too yang, too heat ridden, your energy is too hot, it gets a bit overactive, becomes out of control. Now, how would you know whether somebody was in a yang state or not? First, if you look at them, they might look very red-faced. And if you look at their tongue, they stick their tongue out at you, the tip of the tongue might be red. Tongue diagnosis is quite big in Chinese medicine. I don't know a lot about it, but certainly you would get people to stick their tongue out so that the practitioner could assess their health and well-being from the tongue. They might also become very hot-tempered. So if you think about the premenstrual phase, where people are all irritable and eating chocolate all the time, then you know that is a yang situation, because they're very hot-tempered, they feel hot. You know, they're probably wanting cool drinks to cool themselves down. So we don't want too much yang activity. If, however, somebody was seeing an acupuncturist or a TCM practitioner, the treatment would aim to get rid of some of that heat. Conversely, if somebody is too yin, then everything slows down. Everything slows down, and they get very pale. They are really rather slow and perhaps a bit lazy if it's a long-term thing. They become very dispirited and they sink into themselves. And that means they're too yin. So the treatment would aim to warm everything up and rebalance the yin-yang event, you know, make sure that you're in better balance. Now, what about traditional Chinese medicine theory for breech? So it is believed that two of the energy lines, two of the meridians called the kidney meridian and the bladder meridian, they link with the uterus. The kidney energy is used to nourish the embryo and fetus and encourage the growth of the baby. And if the mother is yin, if there is yin, if she is deficient in yin energy, it means that there is an impact on the muscles in the uterus, and therefore the baby is unable to maintain its head down position. So we want to do some work on the points on the bladder meridian, which link to the uterus and the sacral nerves. And if you can tone the uterine muscle by changing this yin-yang balance and making it a bit more yang, then that will help to stabilize the position of the baby and encourage the baby to revert to head down. And particularly because moxibustion, we work on a point on the toes, and the function of that particular point is specifically to encourage downwards movement of the fetal head. So I'll come back to that in just a second. But when we do moxibustion, it is using a heat source, because we've said the person is too yin, we need to get the yang energy increased. So we're going to use heat to correct the imbalance between the yin and the yang energy. And we use something called a moxa stick, or moxibustion stick, which is made from mugwort, a herb called Artemisia. Now, mugwort in its herbal format is actually toxic, but you're not going to take this by mouth. It is simply used because when you set fire to it, it burns very, very slowly with an intense heat. So there is no harm in using a toxic herb because you're not, well, you will inhale a bit, but you're not taking it by mouth. So it's not being absorbed into your gastrointestinal system, and therefore it's not really a problem. There are some different types of moxa sticks where a piece of charcoal is impregnated with the moxa, the mugwort, and they are slightly different, but they're used for the same point, the same treatment. I mean, moxibustion's been used for thousands of years, and it's not only used to correct a breech presentation, it can be used for all sorts of other conditions in different places on the body and in slightly different ways. When I was I've been teaching in Japan for 23 years or something, and I had a treatment one time I was there with moxibustion as part of it, but it was a tiny little metal sort of cone, like a little triangular shaped cone, and the powdered mugwort, the herb, was stuck underneath this little metal cone on my abdomen, sort of up near the rib cage, for the heat. And I didn't ask what they were doing because they didn't speak very good English, but it had a phenomenal effect, actually. Whatever was wrong with me got better because I felt wonderful afterwards. Well, actually, no, I felt really rough afterwards initially. And then the next day I felt a lot better. And it's a long time ago, so I can't remember why I went, but it was an interesting experience. Quite often you'll find that if moxibustion is done by an acupuncturist, even for breech, they will also combine it with acupuncture. So that's the needling of some other points. What we want to talk about is moxibustion for breech, which is applied to the bladder 67 point. Now, the bladder meridian runs all the way down the body. So it starts actually in the inside corners of the little of the eyes, and it goes up over the top of the head, down the middle of the back, either side of the spine. And when it gets to the waist, it divides. So there's actually 4 bits, 2 go down one leg and the other 2 go down the other leg. And then they join back up again down near the feet, and they finish in the outside corner of the little toenail. So it's a tiny little point. You can just about see it here. And it's called bladder 67. This one is bladder 1. And then you go all the way down until you get to number 67, which is on the toes. It is a point which you shouldn't stimulate in earlier pregnancy because it does have some impact on the uterus, even in the first trimester. So you wouldn't want to use it because it could, theoretically, I think, cause threatened miscarriage, for example. It's used in non-pregnant people for a whole range of other things, but for us, it's a really good point for turning the baby to head first. So how does it work? Well, what we do is we take the moxibustion sticks and light the end, then blow out the flame and let it smoke. So it's a little bit like a very, very large incense stick. When I was still at the University of Greenwich, I had a clinic in one of the local hospitals. Every Monday for 10 years I had it. And in those days, we didn't really have to think about things like fire alarms or clinical guidelines or anything like that. So I would do this moxibustion and treat women with breech presentation. But it is quite hot and it does smoke, especially the paper wrapped sticks. They smoke, and it smells like marijuana. Not that I would know, of course, but it smells like marijuana, apparently. It is very strong. And of course, these days, the fire alarms in hospitals are set so sensitively that you probably wouldn't be able to do it. So what we do is we teach people what to do at home because it's an easy technique to do. But what the belief of how it works is that the heat increases adrenaline and noradrenaline, which helps with enhancing the immune system, and it does impact on prostaglandin hormones. Overall, that is thought to increase muscle sensitivity. So the myometrium, the muscle layer in the uterus, is basically encouraged to become toned up better. And there is also a slight rise in fetal activity. If you were to put somebody on a CTG monitoring machine during a course of moxibustion, you'd see the fetal heart rates going up and about all over the place, not abnormally, but you can see that there is increased fetal activity and fetal heart rate. And so it's a combination of the heat going through the energy line, which then causes a little bit of give in the uterine muscles and encourages slight stretching of the uterus, combined with a slight rise in fetal activity. So basically, if that baby's meant to turn, it'll turn, and it'll turn right round. Now, it is something like 66 to 68% successful, but it is better in a baby that has not got extended legs. If you've got a baby in this sort of position with one leg lower than the other, or if you've got the 2 legs up in front of the face, it's going to be slightly less successful, but it's certainly worth a try. The contraindications are pretty much the same as the reasons not to do an ECV. So if someone's been told you can't have an ECV because of all sorts of reasons and the doctor's not going to try and turn the baby, that woman should not be trying to turn her baby using moxibustion. And one of the problems is, or maybe it's not a problem, but it could be an issue, is that you can buy moxibustion sticks in Chinese medicine shops and in some health food shops. And of course, people do want to do things themselves, and I'm a big advocate of, you know, facilitating and empowering people, but they might not necessarily know the reasons why they shouldn't be trying to do it. So, you know, often you find if somebody's had a cesarean last time and it was for breech, and this time they want to try for a vaginal breech birth, unfortunately, the heat and the effect on the uterine muscles from moxibustion can sometimes stress the scar on the uterus from the previous cesarean, with a small risk, a very small risk, that the scar might burst open. So you know, obviously that's not going to be safe. So we generally say if somebody's had a section within the last couple of years, they shouldn't be doing moxibustion. They won't be having an ECV either. Other things make sense. Any bleeding in pregnancy, any abnormalities, and I use the word in the widest sense, but the abnormalities that don't fit conventional normality, shall we say. So somebody's got twins or triplets, if they have a baby that is a bit big or very small, you might need to look at that. Any history of potential preterm labour in this pregnancy or in a previous pregnancy. Things like not enough fluid around the baby or the membranes having ruptured early. Diabetes mellitus is not in itself a reason not to do an ECV, but of course there is a risk that the baby may be bigger. Depends on the sugar tolerance of the mother, but diabetes is usually classified as a contraindication by medical staff for ECV. If they are already booked for an elective cesarean for some other medical reason, you don't want to interfere with it. You just, you know, you shouldn't really be doing moxibustion. And if they've got a temperature, again, there may be something else going on, some infection brewing. So all of those in ordinary font here are common reasons not to do an ECV. So if she's been told, no, we're not going to do an ECV, then she shouldn't be trying moxibustion. There are two other conditions that will make moxibustion specifically, as opposed to ECV, contraindicated. One is if they've got any severe respiratory conditions. So if they've got really bad asthma and they have frequent asthma attacks and that sort of thing, or if they've got a diagnosed medical respiratory condition, then the smoke from the sticks might aggravate that. Not so much hay fever, because that tends to be an allergic reaction. But if there is a lot of the smoke from the sticks, then it can make them, it can make them very ill, actually. And also, if they're experiencing hypertension, whether that is pre-existing blood pressure problems or pregnancy-related hypertension, they shouldn't be doing moxibustion because it temporarily can put the blood pressure up during the treatment. So those are the two sort of specific moxa contraindications. And then obviously some fetal ones, the baby's too big, the baby's too small, if it keeps moving around all over the place, if it is oblique, lying diagonally across the uterus, or transverse. You'd know that from if you can access the hospital notes. Although, of course, not many people have handheld notes now, they're digital notes. But you can ask them, do they know what position the baby is in at this point? Any reasons to think that the baby is not well or has died, then obviously you're not going to do it then either. So these are the moxibustion sticks. Now the ones at the top, these are the paper wrapped ones with the dried herb, the mugwort inside. And these at the bottom are charcoal impregnated ones. These sticks, I think they come in packs of 10. Yeah, they do. Packs of 10, or it might be 12, I can't remember. But they're about £7 or £8. And you're only going to use 2 or 3 per person. So then it's not expensive. These ones are a bit more expensive. They might be as much as £15 for only 5 sticks in a pack. But obviously, that in the greater scheme of things, when you look at the price of a cesarean and everything goes with it, you know, it's nothing. And this is why it's so good. A little bit of time, which, you know, obviously costs money, but mainly the sticks cost absolutely nothing. The important thing when you're advising parents about buying them is that they must be mild Moxa, and it's got to be suitable to use in pregnancy. And the reason for that is that there are actually different types of Moxa sticks, some of which are impregnated with something else, some other chemicals, which may be toxic. Well, not toxic, but they may not be particularly good for pregnancy and for the fetus. So you have to ask for mild Moxa. I get mine from a place in Camden Town called Acumedic. I often go there, but you can order them online. However, I would advise you to advise your clients to phone Acumedic for the first time, because they need to tell them they want these mild Moxa sticks, not something else. And they will be left with some superfluous ones, which they can always give to you, or you, if you're doing a consultation, you could provide them with the sticks as part of that. I would say with these type, you probably need to give them 3 or 4, because they can sometimes burn down quite a bit quicker than the charcoal ones. They probably only need 2 of those for a course of treatment. And what you do with the sticks is, with the paper ones, you have to peel off a little bit of paper. I would say about 1 inch, no more than 1 inch. The more you take off the paper, the quicker that bit of exposed Moxa will burn. And you actually don't need too much. You need about 1 inch of paper taking off. And then you light the end with a match or lighter. You blow the flame out, and then you have to make sure that the entire surface of the end of the stick is lit. And it's about a button size, I would say. Once one of the consultants once asked me, why didn't I just give people cigars and let them do that? But that would be no good, because, okay, it's hot, but it's not got this special Moxa in it, which burns very slowly, but with an intense heat. It should continue to smoke. It should continue to feel hot. You want it to feel hot. The charcoal impregnated, or so-called smokeless, certainly a lot less smoke than the other ones, they are quite difficult to light. It takes a fair few matches, if you're using matches, to get the end of the stick. So you want the whole of that end of the stick to be alight, and then you blow it out. But they do burn more slowly than the paper covered ones. So, I mean, you know, when I was seeing clinical clients, I would ask them which they preferred and explain the difference. And I remember once going to somebody who lived in one of the apartments that had been converted from the barracks in Woolwich. And they had really thick brick walls for the building, and they had porthole type windows. So the couple decided they would have the paper sticks. I said, okay, that's fine, but if you're not sure about them, phone me. And the next day they phoned and they said, we couldn't open the window and it was so smoky. We both had to go to bed and have a lie down because it was just horrible. So I had to send them some of the charcoal ones. And you might need to say to people, if the weather's okay, do it with the back door open in the kitchen, or go outside and do it in the garden, especially with these paper ones. First time I did it in the hospital, I had a really woolly jumper on. And when I got home, my then husband said, what have you been doing? You stink like you've been smoking cigarettes all day. And the woolly jumper had absorbed all the smoke, and it really did smell quite strong, actually. So they are strong smelling, and they do, you know, the paper wrapped ones will smoke a lot more than the others anyway. So what we would do is, obviously we need to assess that someone is suitable to have moxibustion for breech. That means we need to be sure that the baby is breech and is not transverse or oblique, ideally, what we're going to do is teach the parents how to do this treatment for themselves. And if they were to see you for a consultation, either the day or the day after they've had an appointment at the hospital or with the midwife, you would be then fairly certain that whatever presentation of the baby was recorded would still be the same, especially if they've had a scan yesterday and it's showing a breech presentation. If for some reason the baby has already turned to head first, it's not the end of the world. You can't palpate the abdomen to confirm that. Really, you shouldn't be doing that. But because the point that you work on encourages downwards movement of the fetal head, if the baby's already head down, it's just going to help it go down into the pelvis and become engaged. So it's not really a bad thing. And the best time to do the treatment is around about 34 weeks. So a window of 33 to 35. The earlier you do it, the more likely it will turn to head first, but then it's very likely to turn back again because it's just too small to stick in its own position. I have known it done at 38, 39 weeks, actually. And once we had someone come in at 40 weeks for cesarean for breech, and she'd finished her course of Moxa that morning. And when she got in the hospital, the baby had turned. So they turfed her out of theatre and said, go back to the labour ward. And she was fine. So it does work and you can do it later, but optimum time is around about 34 weeks. We would want to make sure that the baby's movements are okay, that everything seems as normal as we would expect. And then we get ready to help her with the treatment. She needs an empty bladder and some loose clothing, and then she needs to sit in an armchair or sit reclining, if she's got a garden chair or something, with her feet up in front of her. And we then use the lit stick across near the bladder 67 point. So it's about a centimetre away from the skin. We obviously don't want to put it on the skin because that would burn. And we want to do 15 minutes of going from one foot to the other. So if you're teaching a couple how to do this, the best thing to do is to get the partner to do it. And he or she will then hold the stick here until the woman says, oh, that feels hot, more uncomfortably hot. Go over to the other foot and do the same until she says, no, that feels really quite hot. And you just keep alternating across between the 2 feet. At the same point, the bladder 67 point, which is right on the lower corner of the little toenail. And this treatment should be done twice a day for up to 14 days. Some people say 10 treatments, some say 14. As a guide, I would say twice a day for 5 days. That will be 10 treatments. And if there's still no sign that the baby may have moved, carry it on for another 4 days. So, another 2 days. So you've got another few treatments there to do. And as I say, it is, really quite successful in many, many pregnancies, actually. So what are the effects that may not be quite so good from the treatment? Well, it will make the baby more active. That shouldn't be too bad a thing, but if there is any concern that the baby's going mad, then obviously it's better to stop it. If you're unsure, it's better that the couple stop doing the treatment until everything's been checked. But it is normal for the baby to become more active during the treatment. Obviously, sometimes the baby may not turn, or it may turn and go back, or the mother may experience some abdominal discomfort. But those are generally okay. The adverse effects that are possible from this treatment, the breathing problems because of the smoke, but opening a window or something should ease that. Being burned, having burns on the skin usually is because the stick's been held far too close or somebody's not been concentrating. And over the years, there have been attempts to make a piece of equipment that the woman can put the feet on, and then the sticks will be coming out from the side to sort of go like that. But of course, that might work if she keeps her feet absolutely still. But if she, moves her foot one way or the other, then there is an increased risk of burns. Allergic reactions sometimes occur. It's more likely to be respiratory allergic reactions, but they're very, very, very rare. Some long time ago, probably 15, maybe even 20 years ago, there was a study in China of thousands, something like 10,000 moxibustion treatments. And they found the incidence of all of these adverse effects was incredibly low. Burns was a more significant one, but we're talking tiny amounts. And of the 10,000 people who had the treatment, some of them were clinically unwell, perhaps elderly, maybe poor manual dexterity when doing the treatments, that sort of thing. So it wasn't a particularly good study for pregnancy-related moxibustion, but it did show that the amount of side effects is minimal, really very, very low indeed. Bleeding and infection, yeah, very, very rare. I would say the respiratory issues one, if you're using the paper-wrapped sticks, burns if you're not careful how you hold it. Now, this is the rub for all of us, actually, midwives as well as doulas. The only practitioners, professional practitioners, who are allowed to do the treatment are fully qualified acupuncturists. Their insurance covers them to perform moxibustion treatment. The rest of us have to do what is classed as antenatal education. So we are not physically going to light the stick and hold it near the bladder 67 points and do the treatment. When we have our moxibustion study days, sometimes people say, well, I feel a bit cheated now. I've come on a moxibustion study day and you're saying I can't do the treatment. You are doing the consultation. The fact of physically holding the sticks next to the acupuncture point can be done by the partner. So what I would suggest you do is you do your assessment, you work out whether it appears as if this is going to be safe for this particular individual. You can show them the stick, you can hold it next to the acupressure point without lighting it. You can light it to show them how to light it and blow it out or stamp it out to tell them how to extinguish it. You can light the stick and give it to the partner and let them do the treatment under your supervision. But it is a matter of semantics. You just cannot light the stick and pass it across from one bladder 67 point to the other. Does that make sense? It really is a matter of semantics. And if you happen to be covered by FEDANT, the Federation of Antenatal Educators, they've got it in their heads that moxibustion is something to do with labour, and of course they don't cover for birth itself. So we have to be very careful. I say to the midwives, do not tell them that you're doing moxibustion. Don't even mention the word. You are doing it as antenatal education, and so would you be doing it as well as, teaching them how to do it. So you want to obviously discuss the options. You might have an opportunity to talk about the ECV, the section, and the vaginal breech birth. You're going to explain the procedure to them if they've agreed to try moxibustion. And as I say, you can demonstrate lighting the stick, because it can take a little while, blow the flame out. To extinguish it, the easiest thing to do is just to tap it into a glass or ceramic little pot and just stamp it on the bottom of the pot and leave it there. If it's a jam jar or something, so it's a bit taller, you can just leave it in there. I was always worried when I was doing actual treatments at the hospital years ago that when I blew out the stick, sometimes they can reignite, and I just worried somebody would be on the bus on the way home and it would burst into flames in their handbag or something. But it never did happen, but I was always worried about that bit. So, you know, this is about your insurance cover. It's about not stepping outside boundaries. Midwives are constrained in the same way. So you're going to talk to them about it. You're going to demonstrate it, but you can't physically do it, but you can supervise partners or birth companions doing the treatment themselves whilst in your presence. And that's the only difference, really. Oh, seems to have, hang on. That's it. So I think I mentioned before, there is research to show that it's really significantly successful, somewhere between 66 and 68%, even as far as 39, 40 weeks. And if it doesn't work, it is shown also to increase the success rate of external cephalic version if it's done, you know, fairly shortly afterwards. So it's well worth saying to them to have a go at this. It is much more empowering than simply submitting to an ECV or a section. And if it doesn't work, maybe it increases the success rate of the doctor trying to turn the baby. Acupuncturists would say that they tend to use acupuncture from late pregnancy, 37, 38 weeks. It tends to be more successful. And some acupuncturists will combine moxibustion with needling as well on different points. There has been quite a lot of moxibustion research for breech. It is one of the better areas of complementary therapies in terms of research studies. Sometimes it can be difficult if you're doing a randomized controlled trial because they're not blinded. Normally, the best type of trial would be one where neither the person receiving nor person doing the treatment knows what treatment whether they've had a test treatment or something else. So that does slightly slow it, but it's not a big influence in Moxa studies. There is a bit of variability between the studies that are done in China and those that are done in the UK, and between those that use Moxa on its own and others where they're using acupuncture. And there are some variations between cultures and compliance. There was a study team of obstetricians in the very late 80s and early 90s. Cardini was the lead obstetrician, Italian. And their first study they did in China and found it to be significantly more successful than ECV and the control group. So that was good. They then repeated the study a few years later, something like 1992 or 93, in Italy. And they found real difficulties with the study because Italian women were far less compliant about turning up for their treatments or doing it themselves than Chinese women were, where, of course, they're very deferential to authority. So the results were not as good in the Italian study by the same team as the Chinese study had been. And it's quite interesting when you look at some of those cultural variations and the way the people in the study respond to what they're meant to be doing. So yeah, that's a bit variable. I won't go through all of these, but this is some of the early work. There's the Cardini studies there, and this one was the Italian one. This one at the bottom, Kanakura, was a Japanese study, but they had a 92% success rate. But they did start doing Moxa from 28 weeks, which is a bit silly, really, because the baby was too small to stay in one position anyway. And a lot of the studies will involve acupuncture as well as moxibustion. More recently, we can see in some of these that the first figure is the Moxa and the control is the second. So, you know, here 72% versus 63%. And here in 2019, 62% effective with 98% acceptance, 91% compliance when they were doing it themselves, and just 37% compliance when they were coming for Moxa and acupuncture. And that's, I think, was because that was another Italian study. was because people had to go for the treatments, and they're done twice a day. So it's another reason for arguing that it's better if the parents themselves do the treatment, because they don't have to go anywhere. It would also make it extremely expensive if they were going to an acupuncturist twice a day for 5 or 7 days. The latest study was Sarsmas et al. 22, and again, a good success rate around the average, 66.7% for moxibustion versus 48% for the control. It's quite interesting, though, because between about 2008, 2010, and 2015, there were quite a lot of moxibustion for breech studies, and they were all very good and very showed good effectiveness. After 2015, there was then a bit of a sort of hiatus. And you'll find a couple of systematic reviews where people have found all the other studies and done a compare and contrast job, but there's very little new research. This is the latest, the one at the bottom, but there aren't that many. There were loads in the decade before, but it tends to go a bit like that, really. So it's been quite a lot of time there. So hopefully we've got some time for questions. But it is cheap. It's great for the parents to be able to do something for themselves. If it doesn't work, it's not the end of the world, because they can still have an ECV, or they can have the cesarean, or even though they may not want one. But at least it gives them a fair chance that that baby will turn. And I think this should be offered as a routine option within conventional obstetrics. And also, all of us, midwives and doulas, can classify it as antenatal education to encourage people to give it a go, really. I think it's also important, if you are talking to parents who've got a breech in the early, 3rd trimester or late 2nd trimester, not to rush into it. If you can keep them calm and cool, then, sometimes their body will do that work anyway, won't it? So that, I will stop the sharing. We've got this PowerPoint available for you in a PDF format, so you can have that. But I'm sorry, I've gone on for ages, actually. Any questions or thoughts?
I have some geeky questions. If
go ahead.
So 2. One is the I can't remember the success rate of ECV.
It's about 50%.
By any chance? No.
It's about 50%.
Yes, I was going to say it's more.
It's neither here nor there, really.
That's what I thought. Yeah, that's what I thought. And the other one was that you were saying about diabetes contraindication. Is that only to do with the size of the baby, or is it also actually because of potential diabetic neuropathy and not being able to feel the heat?
Yeah, well, not so much the neuropathy, but no, it's more to do with the heat and impact on glucose and that sort of thing. I mean, the problem is that gestational diabetes is considered a problem, again in inverted commas, because it doesn't have to be, but it is definitely classified as such. And I often say, in respect of complementary therapies, we have to be doubly certain, really, because there is still that skepticism. If we've allowed something and it goes wrong or it doesn't work, then sometimes the obstetricians are picking up the pieces. And I think there are certain people in whom it wouldn't be professionally wise, I think, to suggest complementary therapies. And I'm talking in the broadest sense. And diabetes, gestational diabetes in particular, tends to be classified as a complication. I mean, it is arguable, but it tends to be classified by obstetricians as a complication. I do think we overdiagnose gestational diabetes, but the other category that I haven't mentioned is anybody going through gender reassignment should not really be using complementary therapies either. We don't yet know enough about how therapies and the medications that people undergoing gender reassignment, whether they interact and that sort of thing. So at this point in time, until we know more about those sort of circumstances, I would say it would be contraindication or an extreme precaution. And I know that might not necessarily go down well with some of your clients, but I think it's fair to say we do have to be a little bit extra cautious until we know, things are still settling down in that arena, really, aren't they? Any other major medical complication would obviously be a contraindication. And in fact, on the whole, anybody with medical or pregnancy-related complications shouldn't be using complementary therapies on the whole. Yeah. Has that answered your questions, Shelley, or did you have any more?
Yeah, no, I think so. I mean, I was just thinking about type 1 diabetes rather than gestational diabetes, because
yeah, okay,
less likely to have
yeah.
diabetic neuropathy with that, obviously, because it's short term. But was just interested.
Just that extra little bit of caution, really, I think. Yeah.
It made me quite emotional because it made me think about when I was doing it. So just really briefly, I was doing the moxibustion in my father's conservatory one night. I must have gone there for dinner or something. I got out the garden recliner, put it in the conservatory, opened the windows, started doing it. And my dad walked in, he hesitated, just looked at me. I was lying back. My husband was doing it by my toe. And you could see his face just thinking, what is going on?
Yes.
And you're right, the smell is so strong. I mean, it was really strong. And he just looked at me and I said, it's not what you think it is. And he said, I don't even know where to start. And I was just like, and then afterwards I was telling him, and it really brought me back, actually, when you were talking about it. So, yeah.
Yes, it was the one thing, I think, that really made the obstetricians at Queen Mary's think that I was the resident witch. She's burning sticks down there again.
Love it. And I am interested, actually, on what you said about don't use all of the therapies. So I know that clients do this a bit as well. When they find out baby's breech, some of them will just throw everything at it. And I know that I did that when I did reflexology, acupuncture, and the Moxie. So it just be good to understand a little bit more about sort of, it's not great to do them all, or to do
I think what it does is it overpowers your physiology, and each therapy has a different mechanism of action. So it's like being targeted by loads of arrows, and not one is really hitting the mark. So there's no harm in trying different things, but not all together. So you might start with, say, moxibustion at 34 weeks, and you'd be finished by 35 and a bit weeks. And then it's still not done. Now, it is possible to do another course of the moxibustion. So you could do it for another week, if necessary, if it hasn't turned. Bearing in mind that some won't turn, of course. Or you could do homeopathy, take homeopathic remedies. I would suggest, if they want to do that, that they actually contact something like the homeopathic pharmacies and ask them. There are 2 or 3 different remedies that may work. And that's what I would have suggested to clients if the moxibustion didn't work, and if they hadn't got time to do a second course of moxa. Reflexology actually doesn't turn a breech presentation, and any reflexologist who says it does is not actually really understanding the mechanism of action of the reflexology. And if they were to work on the inside heel, which is where the zone for the uterus is, they're more likely to cause placental separation than to turn the baby. If a reflexologist says they're doing acupressure on the points that we've been talking about, the bladder 67, that's not the same as reflexology. So it may be based on the feet, but they're not actually doing reflexology to turn the breech. They're doing acupressure on the points. And I think there's quite a lot of people who say, well, I had reflexology and it turned the baby. Reflexology can't turn the baby, apart from the overall relaxation effect, in fairness. If all that's needed is for the woman to relax, to allow her body to do its own work, well, that's going to respond to any of the relaxation therapies like reflexology or massage or aromatherapy. I wouldn't combine homeopathy with either moxibustion or aromatherapy, because the homeopathic medicines are very fragile chemically, and they can actually be inactivated by being in close contact with strong odors, so oils or moxa. And if people use arnica, like arnica for postnatal perineal healing and that sort of thing, it shouldn't be stored next to either oils or the moxa sticks. The moxa sticks can just be stored in a cupboard, but obviously I would say they need to do one thing, try it. If that doesn't work, go on to the next thing. The other type of therapy that can be useful is osteopathy or chiropractic, where they'd obviously have to go to a qualified practitioner. But sometimes it's the position of the back of the pelvis. So as the curve of the spine comes down, if they've got a pelvis which tilts up before it starts going round, so somebody's bottom basically sticks out a bit more than somebody else's, the osteopathy or chiropractic can realign things to make the curve easier for the baby to negotiate. And so there are some techniques that are very useful and very effective if they're prepared to pay for a couple of appointments with an osteopath or a chiropractor.
Yeah, they combine very well.
They do.
Yeah, I'm a qualified osteopath and naturopath. And
are you?
So yes, I combine them.
Yes. Yeah, brilliant. And I mean, in chiropractic, there are things like the Gonstead technique and various other things. I mean, levity of osteopathy as opposed to chiropractic, but they're similar. They're not quite the same, but they're similar. So yes, I mean, I have to say it's the same with postnatal pregnancy. They're trying everything, the dates, the pineapple, the castor oil, the clary sage, etc., etc. When it comes to natural remedies, it's even more important not to combine them, because you're just literally chucking all these chemicals in, and you can get quite serious side effects actually. So less is more. Usually less is more.
I need to get
Denise, you mentioned about the fact that if baby had turned, then don't worry too much, because actually all it will do is bring baby further down into the pelvis.
Yeah.
Is there ever a case for consideration for using moxa just for that, to help that baby into the pelvis?
And thank you for reminding me. I didn't actually say that, but and it's a really good question. No, it's fine. It's a really good question, because you should encourage somebody to complete a course of moxibustion, because if the baby turns to head first, but is sitting hovering around the top of the pelvis, continuing to do the treatment that is aimed at downwards movement of the fetal head will encourage it to engage. There are also, there is a clinical possibility that you could use it for an oblique lie or a transverse lie. I would not. I don't think it's appropriate for anybody other than an acupuncturist who can assess somebody from a TCM perspective. I don't think we should be doing it or encouraging couples to do it. But theoretically, it could work, because it's still encouraging the fetal head to go downwards. If you're thinking that, you've got a high head and you need it to go down, again, there is a clinical possibility that it would work. But I think professionally, for both doulas and for midwives, I would not encourage it, because there may be other factors that impact on why that head is high. So I think it's perfectly possible that it could work, but I don't think that I would encourage them to do it for that sort of thing. Okay. I mean, I would turn to things like biomechanics, for example, which, let's face it, was part of normal midwifery when I was a student. It's a bit like hypnobirthing. That was part of normal antenatal education when I was a student. But there you go. It all goes round in circles. But no, thank you for that question. And I often talk to midwives about, you can't use complementary therapies for everything. And sometimes it's about what is clinically possible versus what is professionally expedient, professionally wise, and to protect ourselves. And that's maybe not the right approach, but it's the culture we live in. You know, I think we have to be a little bit more cautious than perhaps, you know, maybe an acupuncturist would do it, because, and let me ask Shelley, actually.
Yeah,
as an acupuncturist.
Yeah, I mean, I teach biomechanics because of my osteopathic background.
Yeah.
So, you know, it'd be, why is the baby's head not engaging? And I think, you know, much like induction and use of synthetic oxytocin, when babies are not in a pelvis, why are they not in the pelvis? It's because they're not lined up. And basically, if you're then ramming a baby down that's slightly awkwardly positioned, you're going to end up with a, you know, a more significant dystocia and issue. So, yeah, I think you really need to, the why. It's what I always tell my students. Why is that happening? What is going on? And then you can know how to help.
Absolutely.
So, yeah.
Don't meddle. Don't sort of interfere. Yeah, it's a difficult one, isn't it? But I would agree with you. Yeah, absolutely.
Thank you.
Any
questions?
Yeah.
Jo, are you there, or have you? I know Jo was struggling. Yeah, she was struggling to get in, so I know she missed about the first 20 minutes. But yeah,
okay,
that's fine. That's been brilliant, Denise. Thank you so much.
Well, thank you for asking me, and I hope it's been helpful. You know, and if you want me to do anything else another time, I'm happy to help. If anybody wants to get in touch with me,